Everyone, in this class, we'll try to learn about what is high altitude physiology. It is important to note that percentage of oxygen does not alter at high altitude, rather, the barometric pressure decreases. Therefore, the responses at high altitude are due to decreased oxygen tension of oxygen in inspired gas. Hypoxic symptoms appears at 10,000 feet and become severe at 15,000 to 18,000 feet. Above 20,000 feet, barometric pressure is around 50% of the normal value. However, normally the effects are not severe when the ascent is slow while camping at different heights. Compensatory mechanisms develop to adapt to higher altitudes if the ascension is gradual, in phases with the temporary stationing at different heights. Otherwise, acute mountain sickness will develop. What are the compensatory mechanisms? At high altitude, PiO2 decreases oxygen supply to the tissues. To deliver normal quantity of oxygen to the tissues, many compensatory mechanisms activated. Immediate and important amongst them is hyperventilation. Hyperventilation induced by hypoxia is not significantly prominent unless alveolar PO2 decreases below 60 mm of He. Normally, drop in alveolar PO2 to 60 mm Hg occurs at an altitude of approximately 4,500 meter or 14,000 feet. The stages of compensation. The hyperventilation induced by hypoxia at high altitude appears to be in two stages. In first stage, that appears immediately to exposure to hypoxia. Ventilation increases instantly through the increase in the ventilation in small compared to the increase in the ventilation in the second stage. The hyperventilation in the first stage is mainly due to the hypoxic stimulation of the carotid bodies. The magnitude of increase in ventilation is less because the hypoxic stimulation of peripheral chemoreceptor is opposed by the decrease in the arterial PCO2 that occurs due to excess removal of carbon dioxide induced by hyperventilation. The decreased arterial PCO2 and alkalosis together blunt the hypoxic response. In second stage, ventilation increases slowly in 8 to 10 hours and then remains sustained. The sustained increase in the ventilation is due to the ventilatory acclimatization at high altitude. Ventilatory acclimatization is physiological response that occurs during prolonged exposure to hypoxia. After 2 weeks, hyperventilation induced by hypoxia reaches stable plateau. There are two mechanisms for ventilatory acclimatization. One is chemoreceptor mechanism. The pH of CSF is more alkaline in the acute phase. However, ventilation stimulated by hypoxia brings pH close to the normal by normal movement of carbon out of the CSF. In prolonged exposure to hypoxia, sensitivity of carotid body to arterial PO2 also alters. Second is renal mechanism. The alkaline blood pH that occurs due to the hypoxia-induced hyperventilation opposes the hypoxic response that decreases ventilation. However, kidney compensates pH by excreting more bicarbonate. This decreases the blood pH towards normal in about 3 days. Thus, the effect due to alkaline pH are minimized. This allows hypoxic drive to further increase minute ventilation and then attain a steady state. Acclimatization at high altitude. When person ascends to high altitude and stays there for longer period, he slowly gets adapted to the new environment. This process of adaptation is called as acclimatization. The acclimatization at high altitude starts within 12 hours and may take several days or weeks to complete. The maximum height up to which adaptation occurs is 18,000 feet. Beyond this level, the subject needs oxygen inhalation for survival. Adaptive changes mainly occur in respiratory system, cardiovascular system, blood and tissues. The primary object of objective of all these changes is to increase oxygen supply to the tissues. Respiratory changes. Hypoxia stimulates peripheral chemoreceptors. This increases the pulmonary ventilation by increasing rate and depth of respiration. Consequently, carbon dioxide is washed off and alkalosis develops, which is called as a respiratory alkalosis. Alkalosis counteracts stimulating effects of hypoxia. The kidney corrects the blood pH by excreting HCO3 in urine. Thus, the urine becomes alkaline. This helps the response of respiratory center to hypoxia to continue so that the pulmonary ventilation is maintained at higher levels. Ventilation also steadily increases due to the active transport of H plus ions into the CSF. Though ventilatory response decreases slowly after 4 days, it remains permanently above the pre-exposure level. After about 4 days of acclimatization, ventilatory response slowly increases, which also depends on the level of altitude. As the altitude increases, magnitude of response increases. Ventilatory equivalent increases with increase in the height of the altitudes. Ventilatory equivalent is a better index of ventilatory response. So V is the ratio of expired minute volume VE to the oxygen consumption, that is VO2. Diffusion capacity of the oxygen and MVV are more permanent high altitude residents. So this is the ventilatory equivalent. I mean, it is going to increase as and when the altitude is going to increase. Hematological changes. The hematological changes that improve oxygen supply to tissues include increase in the red cell production and improved oxygen transport. Hypoxia stimulates production of erythropoietin. The erythropoietin-induced erythropoiesis starts in about 3 days and continues till the person remains at high altitude. Increased red cell mass facilitates the oxygen delivery to the tissues. Oxygen supply to the tissue is also favored by increased concentration of 2,3-DPG in the red cells. Increased 2,3-DPG shifts oxyhemoglobin dissociation curve to the right side. Though initially oxyhemoglobin dissociation curve to the left side due to alkalosis, so which favors the release of oxygen from hemoglobin in the tissues. Coming to cardiovascular changes, in the early phase, heart rate, cardiac output, and blood pressure increase. These changes occur due to activation of sympathoadrenal axis by hypoxia. Gradually, heart rate returns to normal. However, some people may continue to have a high blood pressure. Increased cardiac output helps to increase blood flow. Hypoxia causes vasodilatation in the systemic circulation that adds to the increase in the blood flow and oxygen supply to the tissues. Though increased red cell mass improves oxygenation of tissue, significant polycythemia, that is increased hematocrit, increases the viscosity of blood, which in turn increases the workload on the heart. This leads to cardiac hypertrophy. Tissue changes. Following tissue changes occur especially in the skeletal muscles. There will be increase in the number of capillaries. There will be increase in the number of mitochondria in the cells, increase in the activity of oxidative enzymes like cytochrome oxidase, increase in the myoglobin content. Angiogenesis occurs due to the release of chemicals from the hypoxic tissue that stimulate formation of new blood vessels. What are high altitude in illness and the types? High altitude illness includes acute mountain sickness, chronic mountain sickness, high altitude cerebral edema, and high altitude pulmonary hypertension and edema. The sudden exposure to high altitude leads to development of certain signs and symptoms that are together referred to as acute mountain sickness. Usually, people develop fatigue, dyspnea, nausea, vomiting, diarrhea, headache, insomnia, and palpitation. Loss of coordination, memory, and judgment are not uncommon. Euphoria and emotional changes are also observed. These symptoms appear within 4 to 8 hours of arrival at the high altitude and may last for several days. In hypoxia or in susceptible individual, pulmonary cerebral edema develops. Chronic mountain sickness, which is also called as Monge's disease. This is seen in long-term exposure to high altitude. These people develop malaise, fatigue, hypervolemia, exercise intolerance, and polycythemia. Pulmonary hypertension, right ventricular hypertrophy, and heart failure are quite common. All these features are collectively referred as chronic mountain sickness. Pulmonary hypertension and edema. Pulmonary hypertension occurs due to prolonged exposure to hypoxia. Alveolar hypoxia causes pulmonary vasoconstriction. In chronic hypoxia, smooth muscles in pulmonary arteries undergo hypertrophy and hyperplasia that cause narrowing of the arterial lumen. So this increases the pulmonary arterial pressure. In severe hypoxia, the pulmonary veins are also constricted that increases the capillary pressure. Increased alveolar capillary pressure causes transduction of the fluid that leads to pulmonary edema. Pulmonary hypertension also increases the workload on the right side of the heart, which may cause right ventricular hypertrophy and in severe cases right-sided heart failure. Cerebral edema. The increased capillary permeability leads to cerebral edema, so which may be associated with disorientation and ataxia. In severe cases, coma may occur due to herniation of the brain through tentorium. So how do you treat high altitude illness? The individual who does not tolerate high altitude habitation should be brought to the low altitude at the earliest. The condition immediately improves by descent to lower altitude. If the features of sickness still persist, especially cerebral and pulmonary edema, if they continue, the following treatment one should start. Diuretics. They are very useful for the treatment of cerebral edema and pulmonary edema. Acetazolamide is a preferred diuretic. It inhibits carbonic anhydrase and increases bicarbonate excretion in urine, thus decreases the alkali load. It also decreases the formation of CSF. Steroids, glucocorticoid decreases the cerebral edema. Hyperbaric oxygen is very useful if pulmonary edema is present. Nifedipine is a calcium channel blocker which is going to help to reduce pulmonary arterial pressure. And other drugs which improve general conditions. So this is in brief about the high altitude physiology. Thank you.